So you got to see a demonstration of how the AED was used in the other video, but I would like to talk specifically about the AED. There are some things we need to talk about with that. So AED stands for Automated External Defibrillator. And I'm not sure why there's a bighorn sheep in the background. This was suggested by the PowerPoint designer. I am recording this from Big Sky, so maybe they know my location and know there are bighorn sheep up here, but I'm not sure what they have to do with AEDs. But anyways, I always get a chuckle out of these. Okay, so we're going to go through what each of those words means. Why is it called an automated external defibrillator? Well, it's automated because it does everything for you. You really just need to remember these two steps for using the AED. Turn it on first and follow the prompts. You always want to turn it on right away because if it does not turn on, we want to send somebody else to go get another AED or wait for, help to arrive or whatever. But we need another AED because that one's not working. The other reason you want to turn it on first is because it's going to talk to you and tell you every single thing that you need to do. So once you get it turned on, it'll talk you through the steps. So that's why you want to turn it on first. From there, it's really simple. You just want to follow the prompts. Just listen to what it tells you and do what it tells you. I used to go more in depth for students on this, you're going to apply the pads first and then stand clear while it analyzes and then do this and that. And really, the AED technology is changing faster than I can teach people now. Your CPR card is valid for 2 years. And in 2 years, the technology is going to be doing who knows what. So to give you a little bit more information on that, when I first started teaching AED, I would always teach, okay, you plug the pads in, it says analyzing heart rhythm, everybody stand clear. And we would all stand clear while it was analyzing the heart rhythm. Now, if the AED tells you to stand clear, you should stand clear while it's analyzing. But I just learned a few months ago that there are some new AEDs that are out on the market where you can actually do chest compressions while it's analyzing the heart rhythm. Because it can distinguish between your compressions and your electrical activity and the patient's heart rhythm. So, like I said, some of these new ones, you don't even have to stop compressions for analyzing. If it tells you to stand clear, stand clear. If it tells you to continue CPR, continue CPR. It's pretty simple. So when I was teaching it, that's what we would do. We'd stand clear for analyze. So that's changed with some AEDs. And then it would say, shock advised charging, right? So that told me this AED has finished analyzing the heart rhythm. Now the battery's charging up to get ready for the shock. And there's a window there in most AEDs where you can get about 15 chest compressions in while it's charging before you're ready to deliver the shock. So part of high quality CPR was always you get in there and you do your 15 chest compressions, and then you stand clear a second time, and that's when you deliver the shock. Well, a couple years ago, I ski patrol up at Snowbowl and they got new AEDs, and I was reading the manual on them, and the AED manual explained that it analyzes the heart rhythm and then it says charging, and while it's charging, it actually analyzes the heart rhythm again. It double checks itself. And if you were to do chest compressions while that particular AED is charging and analyzing, turns out, it'll actually disarm itself and will not allow you to deliver a shock. So right then I stopped teaching, to override what the AED says. If the AED tells you to stand clear, stand clear. If it tells you to continue CPR, continue CPR. But don't think you can outsmart the AED because they're all different. Now, that being said, if you work somewhere and you've looked at the manual and you know how that particular AED works and you're using that particular AED, go for it. Override what it tells you. Do the chest compressions while it's charging, even though it doesn't tell you to, if you're sure that your AED does not reanalyze the heart rhythm during the charge cycle. But if you're, out in public and you grab an AED off the wall, always go back to these two steps. Turn it on and follow the prompts because you never know how that AED is going to operate. For anybody wondering, the AEDs that we got at Snowbowl that do that are called HeartSine, HeartSine. And I believe it's the 680 model, but I think they might all do that. I know for sure the one we got does. So just check your documentation and know your particular AED, but especially if you're grabbing a random one, just listen to what it tells you. It's automated. It talks you through every step. It even has pictures that show you where the pads go and everything like that. Okay, it's external because it goes on the outside of the body or on the skin. Typically, the pads are going to be placed, one of them is going to go on the upper right chest, up above the right breast, way up really high, almost to the shoulder. And the other one's going to go on the lower left, all the way kind of around the side, kind of on the rib cage, really on the side of the body, down below the left breast, around on the lateral placement there. And for the background here, we have a cell. I'm not sure what a cell has to do with external, but that's what PowerPoint thought we should use. So anyways, like I said, pretty interesting how they choose these backgrounds. But this is external as opposed to an internal or implanted pacemaker defibrillator, as some people might have. External goes on the outside of the body. Now, defibrillator is really the interesting word, and we're going to get a little bit into the science here. So there are different types of cardiac arrest. You know, when we're doing CPR on somebody, they're in cardiac arrest, meaning they don't have a pulse, which means their heart is not pumping blood. But there are different heart rhythms that can be found in somebody who's in cardiac arrest. You may know that somebody who has no electrical activity is known to be an asystole. A means without, systole means heart rhythm. So asystole means their heart's not pumping and they have no electrical activity to go along with that. That is not a shockable rhythm. But some rhythms are shockable. And the most common shockable rhythm is called ventricular fibrillation. Now, as we know, the ventricles are the pumping part of the heart where blood exits the heart, where it gets pumped over to the lungs or pumped out to the body through the left ventricle. And fibrillation is the interesting word here. So if somebody has a shockable rhythm, it's commonly ventricular fibrillation or v-fib. And what is fibrillation? Well, fibrillation basically means the heart's quivering. There's some electrical activity. The cells are all doing stuff, but they're not actually working together to pump blood. That's why we don't palpate a pulse, not even a carotid pulse, when somebody has ventricular fibrillation, because the heart's not actually pumping blood or moving blood through the body. It's just kind of sitting there quivering because the cells aren't working together. So I think of a fibrillating heart like an idling motor. It's just kind of sitting there running, waiting for something to happen to actually go into action. So remember, an AED is a defibrillator. So it takes that fibrillating heart and defibrillates it. It shocks that heart back into a normal rhythm so that the heart can actually start pumping blood again so we can get that pulse to return. One thing to keep in mind is that v-fib won't last forever. It's just like an idling motor. An idling motor won't run forever. When it runs out of fuel, it's going to stop. Well, our bodies don't run on fuel. They run on oxygenated blood. And so we can kind of basically fake that gasoline getting to the engine by doing chest compressions. When you do chest compressions on a patient, you're squeezing blood out of the heart and you're pushing that blood, up to the brain and back to the kidneys and down to the liver and all around the body. But you're also circulating blood through the coronary arteries right back to the heart tissue itself. So when you do chest compressions, you're keeping oxygenated blood flow to the heart tissue. The longer that heart has that oxygenated blood flow, the longer that heart can stay in ventricular fibrillation or v-fib or keep idling, if you want to think of it like an idling motor. So when we do CPR, we always talk about limiting interruptions to chest compressions. And that's why it's so important, because when you're doing those chest compressions, you're keeping that heart in fibrillation. So think of somebody goes down and they're in cardiac arrest. We're never going to know what type of rhythm they're in if you're just an EMT, because we can't monitor their heart rhythm and things like that. But just for the purposes of understanding how the AED kind of works, remember they could be in fibrillation. They could be in v-fib, ventricular fibrillation. Their heart could be basically idling when they go down. If nobody sees them go down and nobody starts CPR, their heart's only going to fibrillate for a really short period of time. However, if somebody sees that person goes down and they immediately start CPR and they start those chest compressions, it's going to extend the amount of time that heart's fibrillating. In other words, it's going to extend the amount of time that the AED can actually shock the heart back into rhythm. So what does this all mean in practice? Well, I'm telling you this information because sometimes people ask, well, what's more important, the chest compressions or the AED? Well, one without the other is not great. If you leave that person to go get an AED and you come back 10 minutes later, that heart is probably not going to be fibrillating because it's not been getting oxygenated blood flow for 10 minutes. That idling motor has run out of gas at that point. If you see the person go down and you continue chest compressions and somebody else brings you an AED in 10 minutes, you might have kept that heart in fibrillation. You may have kept the heart fibrillating long enough with that oxygenated blood coming to it. You've increased the chances that now that we have that AED, we can actually use it to shock the heart back into rhythm. So you want to use the AED as soon as possible. As soon as you get it, you want to apply it right away. But you also want to do high quality chest compressions until that AED arrives, if at all possible. So if you're completely alone and you don't have any way to call somebody else to go get the AED, and you have to make that decision, think about how far away the AED is. Is it better to stay and do CPR, or is it better to go get the AED? It depends how far away it is. If it's in the next room, I'd go get the AED. If it's 10 minutes away, I would stay and do CPR, hoping somebody comes by that can go get me the AED. Or I'll put my phone on speaker, call 911, and continue CPR while I just wait for the fire department to get there or the EMS to get there with the AED. So to give you an idea of like what are the numbers on this, what is important, if you look at the survival rate of CPR, the overall survival rate of CPR is about 9%. About 9% of people who receive CPR actually survive. But if you look at witnessed cardiac arrest, meaning somebody saw that person go down and they started CPR right away, that survival rate jumps up to 30%. So they're more than 3 times as likely to survive. In other words, it's more than 3 times likely that that AED is going to actually work to restart the heart if somebody starts those chest compressions right away. So when you hear us hounding you about continuing chest compressions, never stop, only stop briefly for breaths, don't stop for a pulse check and everything, just remember anytime you're not doing chest compressions, that idling motor is running out of gasoline and it could stop at any second. Okay. Last few things with an AED, some special circumstances you might come across. You may come across a patient who's in standing water. Now, if they're just wet, they're outside on a rainy day, that's not as much of an issue. Just dry their chest off, apply the pads. But if they're in actually standing water, so they're in a puddle of water, they're in a pond, they're in a swimming pool, that's an issue. You need to actually drag them out of the standing water, then dry their chest, then apply the pads. Now, if they're on snow, that's actually fine. When water freezes to make snow, the molecules are spread far enough apart that electricity can't travel through snow. That's like you hear people, right? If there's a lightning storm, they're like, get off the lake. But if there's a lightning storm, people aren't like, oh, get off the snow. That's because electricity does not travel through snow. So snow is not a problem, but standing water is a problem. The other thing you may come across is a hairy chest. We need to apply the AED pads directly to the skin of the chest. So if they have a lot of hair on their chest, a lot of times there's going to be a razor in the AED kit. Take that razor, shave off the area where the pads are going to go, then apply the pads directly to the skin. If you don't have a razor in the AED kit, the other thing that's typically in there is an extra set of AED pads. They're very, very sticky. If you have those, apply the pads, rip them off, and they get a free wax drop. And then you can use those new pads to apply to the skin. If they wake up when you rip the pad off and pull the hair out, they were alive and they did not need the AED. Okay, they're not going to feel it. If they have an implanted defibrillator or pacemaker. Now, typically somebody who has an implanted defibrillator and or pacemaker, it's almost always going to be right under the left clavicle or the left collarbone. And that's because the heart is on the left side of the chest. So that's the closest place to put it, is on that left side. Remember, our AED pads are going on the upper right part of the chest and the lower left part of the chest. So they're nowhere near the pacemaker. So if you have somebody with a pacemaker and it's on the left side, it's no issue at all. However, sometimes the person uses that left arm or left shoulder for sports or hunting or whatever, and the pacemaker irritates them when they move their shoulder around. And if that's the case, sometimes the doctor will actually route the pacemaker over to the right clavicle, and it'll be just under the right clavicle. Now, you'll be able to see it really obviously. A pacemaker is about the size of a silver dollar, and it goes right under the surface of the skin. So even if they have a lot of fat tissue or muscle, it does not matter. That pacemaker is going to be right under the skin. It'll basically look like an alien implant The skin will just be hooved up about 1/4 of a centimeter, and it'll look really obvious. Now, if they have that, you want to make sure your AED pads are at least 1 inch away from that pacemaker. So if it's on the upper right collarbone, it may be in your way. You can try to turn the pad on its side, move it down or to one side or the other just a little bit to get away from that pacemaker. But if you can't get at least 1 inch away, your other option is to apply the pads, what we call the anterior posterior placement. Remember, anterior is the front surface of the body, posterior is the back surface of the body. So AP placement would be you put one AED pad right in the center of the chest, basically right on the sternum, just right in the middle of the chest, and the other AED pad would go right in the middle of the back. As long as the signal from one pad to the other goes through the heart, it's going to work. So one on the front of the chest, one on the back of the chest will also work. Another time you may have to go anterior posterior placement like that would be a pediatric patient. Oftentimes the AED pads are very big, and if you try to put them both on the front of the chest of a child, they may overlap. And if they overlap, they're not going to work. So you may have to put one again on the front of the chest and the back of the chest. Definitely with an infant, but possibly with any pediatric. Okay. The last special thing you might come across is a medication patch. People have medication patches for all kinds of different things, and they often will put them on right around their rib cage. So you don't want to waste a bunch of time looking all over their whole body for a medication patch. But if you see one as you're applying the AED pads, and especially if it's anywhere near the AED pads, make sure you remove that medication patch. Now remember, these are transdermal or transcutaneous patches, meaning they deliver medication through the skin. So I know we talked about PPE at the very beginning of CPR, but especially make sure you're wearing gloves when you remove the medication patch. If you touch the medication patch with your bare skin, you're going to get a dose of whatever medication that was. Could be birth control, could be nicotine, could be fentanyl, could be nitroglycerin. You really don't know what kind of day you're going to have after that. So I would make sure you're wearing gloves so you don't get exposed to that. And then just wipe the area if there's any sticky residue left on their skin. Now, one last thing to think about with the AED use is when you open up your kit, you should have pediatric pads as well as adult pads. Now, I think it's pretty obvious you should use the adult pads on an adult and the pediatric pads on a child or infant. However, if you open up your kit and you have the wrong size pads, there's one way that's okay to switch and one way that's not okay to switch. And when I ask people to make a guess, they almost always guess this incorrectly. So the common guess is that it's okay to use the pediatric pads on an adult, right? That's a common guess, and that's actually incorrect. When you plug the pediatric pads into the AED, it turns down the amount of shock that's delivered. So if you apply those pediatric pads to an adult, it's actually not enough electricity to restart their heart. It's not enough of a shock. Now remember, when you're using an AED, you're standing clear to analyze, you're standing clear to shock, and you may be standing clear to charge. Maybe you're not standing clear a whole lot, but you're at least standing clear for the charge, depending on the AED. That's basically time wasted when you could have been doing high quality chest compressions. Because now when that AED shocks that person, it's not enough electricity to restart the heart. And they possibly could have went into asystole at that time and lost that shockable ventricular fibrillation rhythm. So you really want to use caution with that. I shouldn't even say use caution. By using caution, what I mean is do not use the pediatric pads on an adult. It's not enough to restart their heart. You're wasting time. You could be doing high quality CPR. Now, the flip side is okay. If you only have adult pads and you have a child or an infant patient, it's okay to use those adult pads on the child or infant. Remember, you'll probably have to do that anterior posterior placement, one pad on the front center of the chest, one pad on the upper center of the back. So that signal will go through the heart. And it will shock the crap out of them, but it's their only chance for survival. If we're using an AED on them, their heart's not beating. So that's our last hope to try to get them to get their heart restarted. Okay, so that's what I have for AEDs. We'll see you in the next video. Thank you.